Dear students, topic for today's session is anal canal. Anal canal is the terminal part of gastrointestinal tract, that is the large intestine. So here we can see it is the continuation of rectum. So this is rectum, which continues as anal canal. So it is a terminal part of large intestine, which is around 3 to 4 centimeters long, and purely it is extraperitoneal structure. It begins at the anorectal junction distally from the perineal flexure. So the curve here we can see perineal flexure of rectum. So distal to this, here this flexure is the anorectal flexure. So here this is the perineal flexure, this curve is the perineal flexure. And we can see the anorectal junction just lies below the perineal flexure. And it is situated in the perineum below the pelvic diaphragm. Like rectum, it is devoid of seculations, tinea coli and appendices epiploicae. So we know the three cardinal features of large intestine are seculations, tinea coli and appendices epiploicae. So these three cardinal features are absent in anal canal as well. It has an inner involuntary sphincter and outer voluntary sphincter, and whose stone keeps the anal canal closed except during process of defecation. The anal canal is located in the anal triangle of perineum between the right and left fat filled with the ischiorectal fossa. So here is the anal opening, which is located in the anal triangle. On each side of the anal triangle, this space, which is usually filled with the fat, is ischiorectal fossa. So these fossae allow the expansion of the anal canal during defecation. The skin surrounding the anal orifice is pigmented and has radiating folds due to the pull exerted by the underlying subcutaneous muscle, that is corrugator cutis ani. Anteriorly, the anal canal is related to perineal body. So this is the perineum of females. And it is related to vagina anteriorly in females. And in males, anteriorly, the anal canal is related to perineal body, bulb of penis and spongy urethra in the male. So here is the perineal body. And it is related to bulb of penis. And also the spongy part of urethra in males. Posteriorly, anal canal is related to anococcygeal raphe. So the lower tip of the coccyx is connected to the anal canal by a raphe which is called as anococcygeal raphe. And posteriorly, it is also related to the tip of the coccyx. So here is the tip of the coccyx, which forms the posterior relations, and fibrofatty tissue, which is between the perineal skin and the anococcygeal raphe. So we can see fibrofatty tissue. Which is related to the anococcygeal raphe and the anal canal. So it is in between the anococcygeal raphe and the anal canal. So these are the posterior relations in both males and females. Laterally on each side, anal canal is related to ichiorectal fossa. So this is the anal canal showing the interior of rectum and anal canal, and on each side we can see the fat filled area which is called ichiorectal fossa. Gross anatomy of anal canal. Let us discuss that regarding the zones of anal canal. The anal canal may be subdivided into columnar, intermediate and cutaneous zones. So starting with the columnar zone, the lumen has folds of mucous membrane which are called as anal columns. So these folds of mucous membrane are the anal columns. And which are produced by the arterial cavernous bodies which are otherwise called as anal cushions in the submucosa. And these columns are connected to each other at the distal ends of the transverse folds which are called as anal folds. So the transverse mucosal folds, what we can see which connects the lower end of the anal columns, are called as anal valves. And behind the anal valves lie the crypts or the crypts of Morgagni, into which the excretory ducts of the anal glands open. So if you closely observe, just above to each anal valve there will be a depression into which we see the opening of glands which are called as anal glands, and these depressions are called as crypts. They are the crypts of Morgagni, into which excretory ducts of the anal glands open, and all the anal valves together form the dentate or pectinate line. So this wavy line margin is the dentate or pectinate line. So dentate means tooth-like or pectinate means comb-like projections. So it appears to be serrated. So that is the reason it is called dentate or pectinate line. And it is a serrated line where the intestinal mucosa merges with the squamous epithelium of the anal canal. So that was about the columnar zone. And the next we shall move to intermediate zone. Intermediate zone distally from the dentate line lies a 1 centimeter long. It is around 1 centimeter long zone with anal mucosa that is called as anoderm. So it is distal to the dentate line. So this area, this is the dentate line. So below the dentate line from here to here is the intermediate zone. And the way anal columns are there, it is called columnar zone. And next comes the cutaneous zone. The cutaneous zone is below the anal verge, that is anocutaneous line, and it is a hollow between the internal and external anal sphincter and has regular perineal skin. So it is observed with a normal cutaneous layer, that is the skin. So it is just below the anocutaneous line it lies, and it is a hollow between the internal and external anal sphincter and has regular perineal skin, and the tension of the corrugator cutis ani muscle gives it fan-like look appearance. So the tension, because of corrugator ani muscle, we can see the wrinkles in the cutaneous zone. So if we see the interior of the anal canal, it is divided into upper and lower parts by pectinate line. So the pectinate line represents the embryological site of attachment of anal membrane. So the anal membrane, it is the posterior part of cloacal membrane. So pectinate line indicates the line of attachment of anal membrane during fetal life. The upper part of the anal canal extends from the anorectal junction to the pectinate line, and the lower part of the anal canal extends from the pectinate line to the anal verge. The upper and the lower parts of the anal canal are different in embryologic origin. So, blood supply, lymphatic drainage and innervations are also different above the pectinate line and below the pectinate line. So, that is the reason the pectinate line is like a watershed line. So, the development above the pectinate line, that is the upper anal canal, is from the endoderm of hindgut, whereas the lower anal canal is from the ectoderm of proctidium. And if we see at innervation, autonomic nerves supply the upper part of anal canal, that is the upper anal canal. So hence it is insensitive to pain and temperature. Lower anal canal is innervated by somatic nerves, hence it is sensitive to pain and temperature. Epithelial lining of the upper anal canal, it is lined by the simple columnar epithelium, whereas the lower anal canal is lined by stratified squamous epithelium. Arterial supply, upper anal canal is supplied by superior rectal artery, and lower anal canal it is supplied by inferior rectal artery. And venous drainage, superior rectal vein drains into the portal vein in upper part of anal canal, whereas the lower part of anal canal, that is the lower anal canal, drains into inferior rectal veins, which further drains into caval system. Lymphatic drainage, internal iliac lymph nodes drains the upper anal canal, and superior inguinal lymph nodes, especially the horizontal set of superior inguinal lymph nodes, drains into the lower anal canal. And coming about the hemorrhoids, which makes up the major clinical aspect of anal canal. So, internal hemorrhoids are formed in the upper anal canal, that is a clinical condition, and lower anal canal is prone to external hemorrhoids. So, let's talk about little more gross anatomy. So, the upper part of anal canal, it is around 15 mm. So, the anal columns of Morgagni, these are the permanent longitudinal mucosal foldings, which are usually 8 to 10 in number, and they contain radicals of superior rectal veins. So, deep to these columns, there are radicals of superior rectal veins, which are called as columns of Morgagni. The next comes the anal valves. The valves of Morgagni, these are the crycentric folds of mucous membrane which connects the lower ends of the adjacent columns. The free margins of these valves are directed upwards. So, the position of these valves is indicated by wavy pectinate line, which is also called as dentate line. Anal sinuses. These are vertical recesses which are between the anal columns and above the anal valves. So, the ducts of tubular anal glands present in the submucosa open in the floor of anal sinuses. So, let's see the features of lower part of anal canal. So, the lower part of anal canal is further subdivided into two regions, that is the upper and lower region. Upper region is often called as pectin and it is around 15 mm long. So, the columnar part is 15 mm long and pectin is also 15 mm long. So, the pectin extends from the pectinate line of Hilton. So, this is the pectinate line or dentate line. So, from pectinate line of Hilton, often called as dentate line 2, and it is lined by non-keratinized stratified squamous epithelium. So, extends from here, this is pectin. So, the lower region of the anal canal, which is around 8 mm in length, and it is lined by the true skin and has the sweat glands, sebaceous glands, and this part of the skin is pigmented. Blood supply and innervation of anal canal. The columnar zone derives from endoderm, whereas both intermediate and cutaneous zone develops from proctoderm, that is from cutaneous ectoderm. And as a result of different embryologic origins, the zones have separate supplying structures. So hereby the dentate line serves as a watershed line, that is an important marker which differentiates the blood supply. So above the dentate line or pectinate line, the arterial supply is carried by superior rectal artery, which is a branch of inferior mesenteric artery. So we can see the inferior mesenteric artery giving rise to superior rectal arteries. And below the dentate line, the arterial supply is carried by middle rectal artery, which is a branch of internal iliac artery, and inferior rectal artery, which is a branch of pudendal artery. Pudendal artery is in turn a branch of internal iliac artery. So the arterial supply below the dentate line is directly or indirectly the branches of internal iliac arteries. So they are by inferior rectal arteries and middle rectal arteries. So here is the internal iliac artery. So from the internal iliac artery we see the middle rectal artery and inferior rectal artery. So that was about the arterial supply. So next is the venous drainage. So venous drainage is drained via the internal hemorrhoidal plexus into the superior rectal vein. So above the pectinate line, the venous drainage is by hemorrhoidal plexus. So here we can see the pectinate line, and these are internal hemorrhoidal plexus. And which drains into superior rectal vein, and from superior rectal vein drains into portal system. So superior rectal veins. So via the superior rectal vein, the blood is drained into hepatic portal system, and below the pectinate line, the venous blood drains via the external hemorrhoidal plexus, which drains into middle and inferior rectal veins. So we can see the middle rectal veins and inferior rectal veins draining from the external hemorrhoid veins and finally drains into systemic circulation. So the lymphatic drainage above the pectinate line drains into lumbar or para-aortic group of lymph nodes, and below the pectinate line the lymph drains into inguinal group of lymph nodes. The innervation of anal canal. So above the pectinate line, it is supplied by sympathetic and parasympathetic nervous system, that is autonomic nervous system. So the sympathetic innervation is carried by inferior mesenteric plexus. So here we can see the inferior mesenteric plexus. And parasympathetic innervation by pelvic splanchnic nerves, which are from inferior hypogastric plexus. So both are together, inferior hypogastric plexus. Below the dentate line, there is no sympathetic supply. So it is supplied by pudendal nerve, which is responsible for sensory innervation below the dentate line. So internal hemorrhoids occur above the pectinate line, that is due to the superior rectal vein, and they are not painful because of visceral innervation. So here we can see the internal hemorrhoids. Which are above the pectinate line, and they are due to rupture of superior rectal veins or dilatation of superior rectal veins. Next, regarding the external hemorrhoids occur below the pectinate line, and they are very painful because the pudendal nerve provides innervation to this area with somatic innervation. So here are the external hemorrhoids. Microscopic anatomy of anal canal, that is the histology of anal canal. In the anal canal, the intestinal mucosa, which is colorectal zone, changes into anal mucosa, which is called as anodermal zone. So through a transitional zone and finally merges with the perineal skin or cutaneous zone. So colorectal zone, it equates the histological structure of the rectum with simple columnar epithelium, and folds of the mucous membrane filled with the small arteries form the cushions in the wall. Next, about the transitional zone, it resembles the histological structure of the rectum, but it presents both simple columnar epithelium and stratified squamous epithelium. So the characteristically they have some transverse mucous folds with crepes and anal glands, which are the tubular epithelial glands, which are present in the transitional zone. Then comes to anoderm zone. Anoderm or white zone, it has a stratified squamous non-keratinized epithelium which is associated with internal anal sphincter, and this zone features densely packed sensory neurons registering the status of intestinal content. Example, solid, liquid or gaseous. Then cutaneous zone, it is equal to histological structure of the skin with the stratified squamous keratinized epithelium, and it is strongly pigmented, and it has all typical skin associated structures such as sweat and sebaceous glands, Pacinian corpuscles and hair follicles. So that was about the histology of anal canal. So next we shall discuss about the sphincters. So the anal canal is surrounded by muscular sphincter system which tightly closes the lumen. So there are like internal and external anal sphincters. Internal anal sphincter is permanently contracted through the sympathetic tonus and relaxes under parasympathetic influence. So as it is supplied by autonomic nerve fibers, that is the sympathetic and parasympathetic, so hence it is involuntary. And it is formed by a thickened circular muscle coat around the anal canal and surrounds the upper 2/3 of the canal. So here is the internal sphincter. Which surrounds the upper 2/3 of the anal canal, and it is formed by thick circular muscle coat of the anal canal. And above it continues with the circular muscle coat of rectum, and below it reaches up to the level of white line of Hilton or pectin line. So above we can see it is continuous with the muscle coat of rectum, and below it extends till the Hilton's white line. So the internal sphincter is made up of smooth muscles which are not under the control. They are involuntary. Next, regarding the external anal sphincter, the external anal sphincter surrounds the anal canal like a clamp, and it is close relationship to the puborectalis muscle. So here is the external anal sphincter. So here we can see the external anal sphincter is in close relationship with puborectalis, which is a part of levator ani muscle. So here is the external anal sphincter. Which is closely associated with puborectalis muscle. Which is a part of levator ani muscle. Both the external anal sphincter and the puborectalis muscle are voluntary control. The external anal sphincter is made up of striated muscle and hence it is supplied by somatic nerves, which are the inferior rectal nerves, which are the branches of pudendal nerve, and perineal branch of fourth sacral nerve. So it is therefore under voluntary control. The pudendal nerve, which is having the root value of S2 to S4, innervates the external anal sphincter via the inferior rectal nerve. So, injury to the pudendal nerve during childbirth can cause fecal incontinence and perineal sensory loss. The anal cushions play an important role in the fine control. Physiologically, they are filled with the arterial blood, and during defecation, the internal anal sphincter relaxes so that the blood in the cushions drains away and allowing a smooth passage of the stools through the anal canal. And a pathological enlargement of anal cushions leads to hemorrhoid. So let us have a look on surgical anatomical aspects of anal canal. So perianal space, it is the space which surrounds the anal canal below the Hilton's line. So here we can see the perianal space normally. And this space, it contains subcutaneous part of anal sphincter, lobulated fat, external rectal venous plexus, and terminal branches of inferior rectal nerves and vessels. So we can see the lobulated fat and external venous plexus. External venous plexus. So the perianal abscess, so collection of pus in the perianal space is the perianal abscess, which is shown on the other side. So it is very painful because it is supplied by somatic nerve. Next is the ischiorectal space or ischioanal space. So ischioanal space extends from the elevator anus muscle to the perineum and lateral to the anal canal. So ischioanal space is present on each side of the anal canal below the elevator anus muscle. So in this ischioanal space, under a rectal examination can be more directly given access to this space, and it may reveal a cord-like thickening under the mucosa, or there may be granulation tissue or frank abscess, and it is usually indicates anoscopy or proctoscopy to find the location of primary opening. So we can see here proctoscopy is done to locate the abscess location, primary location of the abscess. It is usually indicates the proctoscopy to find this location of primary opening, and the fistulography may be needed to delineate the fistula's track. So here is the fistula, which is between the anal canal and the ischiorectal fossa. So both MRI and CT scans are done in complex cases and for recurrent lesions, and surgery is required to drain the abscess and close the fistula. And next comes to important part in the ischiorectal fossa, which is called as pudendal canal, otherwise called as Alcock's canal, and it is a sheath derived from the fascia of obturator internus muscle, and it is found in the lower lateral wall of ischiorectal fossa. So we can see the pudendal canal or Alcax canal, which is along the lateral wall of ischiorectal fossa, and the fascia is derived from obturator internus, and pudendal canal contains internal pudendal artery, pudendal nerve, and internal pudendal vein. Next comes to intersphincteric spaces, which are located between the two sphincters, that is the internal and external sphincter. So here is the internal sphincter and here is the external sphincter. So the space or gap between the external and the internal sphincter, it continues inferiorly into the perianal space and superiorly with the wall of the rectum. Next is the supra-elevator space, which is also called as pelvic rectal space. It is limited superiorly by the peritoneum and laterally by the pelvic wall and medially by the rectal wall and inferiorly by the elevator anus muscle. So we can see the elevator anus muscle which are present on each side of the anal canal. Next is the deep post-anal space, which is found in front of the apex of the coccyx, and it is limited superiorly by the plate of elevator anus muscle. So here is the tip of the coccyx, and deep post-anal space is here. So the deep post-anal space, it is limited above by the elevator anus muscle. So here is the deep anal space, post-anal space, which is limited by the elevator anus muscle and inferiorly by anococcygeal raphe. This is the anococcygeal raphe, and here is the elevator ani muscle. So let us see some applied aspects also. Hemorrhoids. Hemorrhoids are also called as piles and arise from the cushion dilated arteriovenous blood vessels and connective tissues in the anal canal that may abnormally enlarge and protrude. Hemorrhoids are divided into three categories: internal hemorrhoids, external hemorrhoids, or mixed hemorrhoids. Internal hemorrhoids are above the dentate line. So here in this image we can see the internal hemorrhoids. External hemorrhoids are usually present below the dentate line. And mixed hemorrhoids, they are above and below the dentate line. Hemorrhoids are usually caused by the increased straining or intra-abdominal pressure, and due to constipation, pregnancy, or extended periods of sitting. All these would be the reasons. And the patients with presence with the prolapse and also the rectal bleeding, pain, and pruritus. The diagnosis of hemorrhoids involves the careful inspection of anal area during clinical examination, especially as the patient increases intra-abdominal pressure by straining. Anoscopy and proctoscopy may be necessary to confirm the diagnosis. Internal hemorrhoids are classified into 4 grades depending upon the extent of prolapse. Conservative management is recommended for grade 1 and grade 2, like anal hygiene. Anti-inflammatory ointments are given as a conservative treatment, while the surgical treatment is indicated in grade 3 and grade 4, which is known as Malligan-Morgan hemorrhoidectomy. Fissures in the anorectal canal, it is caused by the rupture of one of the anal valves, that is the valve of Morgagni, and by the passage of hard fecal mass. And an anal fissure can cause pain and bleeding during bowel movements, and they occur posteriorly in the midline and are very painful because the inferior aspect of the valve is lined by the mucous membrane and skin of the lower half of the anal canal, which is supplied by somatic nerves. So this condition usually heals on its own in 4 to 6 weeks. Common treatment include dietary fiber and stool softeners as well as creams to the affected area. Next comes to the anal abscess and fistula. Anal abscess are acute manifestation of a purulent infection in the perirectal area, while the anal fistulas are chronic manifestations of such infections. An anal abscess is pus-filled cavity that is most commonly develops from an infected anal crypt, that is infected anal crypt gland following obstruction and bacterial growth, and less common causes for the formation of anorectal abscesses or inflammatory bowel disease. Acute gastrointestinal infections, example appendicitis, radiation-induced proctitis or malignancy. An anorectal abscess may heal spontaneously following the drainage into the anal canal. In about 30 to 60% of the cases, anal abscess progress into fistulas, which are ductal connections between the abscess and the anal canal or perianal skin. So we can see the ductal connections here between the perianal abscess and the anal canal. So the complications of abscesses and fistulas involve chronic tissue damage, fecal incontinence and sepsis. Patients with an anal abscess present with anorectal pain and a palpable tender mass on the digital rectal examination, and fever is observed in more advanced cases. Patient with anal fistulas may present with a visible perianal site draining pus and discomfort during defecation. Imaging studies such as CT, MRI and anal ultrasonography are needed for the extended abscess or complex fistulas. Definitive management of an anal abscess and fistulas involves surgical treatment, and abscesses are incised and drained followed by open wound healing. And the standard treatment option for anal fistulas is fistulotomy. So this completes the normal anatomy, histology and clinical aspects related to anal canal. Thank you.